everybody, my name is Jessica Brown, and today we are going to be talking about some guidelines that were created by the CDC regarding the management and care of the pediatric population with mild traumatic brain injury. So overall, the goal for this talk is to walk through the different sections of the CDC guidelines and highlight some of the different areas that you might be able to incorporate into your practices as professionals or survivors or caregivers, and really think about how these guidelines can be adapted and used across a variety of settings and with a variety of different types of children. So the first thing that's important to talk about here is the term mild traumatic brain injury. The term mild is really something that I consider to be a misnomer. And the reason for that is that the way injuries are classified are based on what happens neurologically at the time of impact. So let's say that you are somebody that is in a car accident and you experience some sort of whiplash injury, but you don't hit your head very hard on something, or you don't lose consciousness. And you immediately notice that you have maybe some side effects, but those aren't related to the impact at that moment. Your injury might be termed, by definition, mild. That doesn't mean, however, that the symptomology that you are going to experience, the side effects, are going to be mild in nature. So that term kind of throws people off to think that a mild traumatic brain injury might not be a big deal. But for some individuals, and certainly a subset of people, these injuries are not mild in nature in how they affect your life. So when we think about how to define a mild traumatic brain injury, one of the widely used definitions comes from an organization called ACRM, the American Congress of Rehabilitative Medicine. This organization is a multidisciplinary rehabilitation cohort. And their definition for mild TBI has been out since as early as 1993. So this is potentially a little bit of an outdated definition for the concept that we're talking about today, but universally a lot of this information still applies. So the idea of a mild injury, as I mentioned before, is that the initial impact is maybe not causing a lot of noticeable neurological damage at that moment. So what that means is that typically if an individual does lose consciousness, it's for a very brief period of time, less than 30 minutes. They may not lose consciousness at all for it to be considered a mild traumatic brain injury. Another thing that is an important hallmark of this is something we call post-traumatic amnesia. So that term refers to someone's ability to recall new information. Maybe you told them what happened to them, and 5 minutes later they're saying, wait, what happened? You mean I was in a car accident? So they might have an inability to lay down some new memories. That's not going to last for days and weeks, but it could last for up to 24 hours in a mild injury. The other thing is that we can use something called a Glasgow Coma Scale, which is a brief set of questions and tasks that an emergency medical provider, an acute care emergency physician, and someone out in the field, so an EMS technician, for example, could administer this. And we're going to see that people are going to do pretty well on that scale and those tasks. All of those things combine really tell us that this injury, by definition, is again mild in nature. When we're thinking about mild traumatic brain injury, we're talking about 80 to 90% of all traumatic brain injuries will fall into this category. This means we're discussing millions of people each year in the United States that are incurring these kinds of injuries. The statistics on this are a little bit thrown off because the information is gained on the number of individuals that seek medical care. So the people that might go to the emergency room for care, that might be maybe even admitted to the hospital, things like that. So there's a lot of people that experience these injuries that do not ultimately seek medical care. There's a variety of reasons for that. Maybe they don't think the injury is going to be severe enough. Maybe they think that their symptoms are going to go away after a short period of time. maybe they've had many multiple TBIs before and they know what to expect or think they know what to expect. So these numbers are a little bit skewed and are likely underestimates of the number of individuals in the United States and worldwide that are experiencing these kinds of injuries. One thing that we do know when we're thinking about brain injury and mild traumatic brain injury is the impact it has on people's lives. For adult populations, this could be lost wages and employment time. This could be costs associated with rehabilitation for these individuals. In pediatric populations, this could mean changes in school, need for special education services. So the dollar amounts surrounding these injuries every year add up to the billions. The estimates that we have are about $26 billion are spent annually on traumatic brain injury across the United States each year. More importantly, people are experiencing changes to their life, their self-esteem, their quality of life, their ability to perform roles and responsibilities they used to do with ease, their interest in activities that they used to enjoy. The impact of these seemingly mild injuries can be quite great. What happens inside the brain when a mild traumatic brain injury occurs? Well, first and foremost, there are some neurophysiological changes that happen. This happens primarily at the level of our metabolism. So there's changes in glucose use within the brain. There's some potential changes in blood flow. What we often don't see are changes that show up on structural imaging. If somebody has a mild traumatic brain injury and they go in for a CAT scan or an MRI or some sort of imaging, it may show up as being normal. So the changes that are occurring in the brain are typically more related to how the brain talks to itself, how quickly it processes information, how signals are sent between nerves in your brain. And as I mentioned, also changes to metabolic processes. This is a chart that is seen in a lot of presentations from a really great Hallmark study that looks at what is happening in the minutes, hours, and days following the occurrence of a concussion or a mild traumatic brain injury. So as you can see, there are changes to glucose, to blood flow, to calcium, potassium. There are actual things changing in the brain when an injury like this occurs. So although structurally and on imaging, there may not be noticeable changes, quite a bit is actually happening within the brain that's going to result in potentially widespread symptoms that people experience. For children, typically what we see is that following an injury, their brain actually goes into a hyperactive state. So there is increased use of resources. Your brain requires more energy to function at the capacity that it's used to functioning at. And then in a week or week and a half after an injury, that changes and we start to see some decreases. So blood flow to the brain goes down. Your metabolism starts to slow down. So it's a little bit odd. You see kind of a hyperactivity followed by a hypoactivity. This 7 to 10 day period where we see that decrease in metabolism and blood flow is actually longer in adolescent populations. So when you might hear, oh, you'll be better in a week or two, that may not necessarily be the case in some of these pediatric populations. And you can see how maybe the symptoms that are experienced actually correlate to some of the changes that are happening inside of the brain. On top of all of those metabolic changes, we see other things that are happening. Okay, so it's possible that the neurons in the brain are going to rip and be twisted or stretched during an injury. So if your neurons aren't talking to each other as well as they're used to, then you might have slower processing. It might be harder to concentrate, to pay attention. So we might see some changes there. We see changes in your sensory system. So individuals might say that they have balance and dizziness problems. Maybe there's vision changes because our thalamus, our actual sensory system, is going to have some changes. And then we also see change in blood flow and inflammation in the brain. This has been noticeable since the very early 90s. This has been kind of a hallmark of even these mild injuries. So how do we figure out what is going on with somebody or whether an injury has even happened? One of the problems that we experience right now professionally with mild traumatic brain injury is lack of an objective diagnosis. There are things in the works, but there isn't currently biomarkers or imaging that can be done to definitively say, yes, someone has experienced a brain injury and it is mild in nature. So these diagnoses are actually made on kind of two components, what they call observable signs and also self-reported symptoms. So signs are things that you can definitively say have happened. Maybe somebody is vomiting. Maybe they have lost consciousness. Those can be seen by an outside viewer in our objective yes or no, this occurred. Symptoms are a little bit trickier because these are things that the individual themselves might be experiencing, but you can't necessarily see them. So an example of this is a headache. Somebody tells us they're having a headache. The headache may be impacting them in a variety of ways, but that is not something we can objectively identify and define. There are many, many different symptoms that people experience following an injury, which also makes this a little bit difficult. There isn't one pattern of symptomology or deficits that we're going to see. People have a kind of a constellation of symptoms is something that you might call it, because everybody's going to be a little bit different and unique in how their body reacts to incurring one of these injuries. What does this mean specifically in the pediatric population or in children? Well, we know based on some of those emergency room and hospital admissions statistics I told you about before, that we're talking close to 2 million children every year in the United States are experiencing traumatic brain injuries. Again, probably an underestimate since many people don't seek medical care following these injuries. Interestingly, of pediatric patients that go to the emergency room, 1 in about 220 are going there for a mild traumatic brain injury. So think of all the reasons you might go to the emergency room. Kids need stitches, they fall, they're sick and they have a high fever. So you take all of those away and 1 in 220 children are there solely for a potential diagnosis of a mild traumatic brain injury. When we think about how brain injury interacts with other factors or predictors in pediatric populations, we know that children with co-occurring health conditions or mental health disorders or learning challenges are going to have potentially a protracted or worse recovery than children who don't have those predictive factors prior to sustaining an injury. The whole child and the things that they experience are going to impact what happens next following one of these injuries. Ideally, and based on data, we can assume that most children, the majority of children, will fully recover from a mild TBI in approximately 1 month. When you look at adult populations, that timeline is shrinked to closer to about 2 weeks, but for children it takes a little bit longer. So about a month would be the expectation for when a child might fully recover from a mild injury. About 30% or a third of kids will demonstrate persistent symptoms beyond that time frame. So the 1 month might be used as a little bit of a hallmark or kind of just an indicator on a calendar to say, we think they probably should have gotten better by now. But we're going to see that for some children, the recovery is going to take longer than that and can persist multiple months and even years after an injury has occurred. One thing that's a little bit different about this to point out is that when we look at athlete populations that experience these injuries, their recovery is going to be closer to a 7 to 10 day period. There's a lot of factors that relate into that, such as physical health prior to injury, lots of services that are built in legislation to support children and adults that experience sports-related injuries. But in the general population, we're talking about a month with about a third of people of children specifically whose recovery is going to be longer than that time frame. As I mentioned, there are some things that are going to contribute to the persistence of symptoms. The statistics vary widely about what exactly are the most predictive factors here, but when we work with children, we sometimes see that symptoms actually are going to get worse over time. So not only do they persist and are they still present, but they may even grow, new symptoms may appear. Some of that could be due to psychological factors, anxiety, stress, depression, some mental health concerns or behavioral concerns can exacerbate or contribute to prolonged and new symptomology. Social and environmental factors, things in the home. I had a 12-year-old come through my clinic, and the father was very concerned about the child. He had a lot of stress and anxiety about her injury, and he felt that she was having a lot of persistent symptomology. However, when we evaluated her, we felt that she was actually doing quite well. So some of those social and environmental factors were influencing how she was performing in school, her engagement with other kids, her ability to complete academic tasks. So the whole student, the whole child, the whole person must be considered. This is a quote that I really like. The manifestation of post-concussion symptoms likely represents the cumulative effect of multiple variables. This could be genetics, mental health history, life stress, medical problems, chronic pain, depression, substance abuse. We're talking about a really holistic view of what happens to people after they experience these injuries. There are guidelines for some professions or for some certain populations of individuals with mild TBI regarding care and support that happens pre and post injury. Two that are pretty widely known and understood are military and veteran populations and athletes. When we think about the general population, so the people just living and working in our community, children going to our schools that might be injured in any way, there's less evidence to support specific procedures that should be in place. There's also not a lot of legislation or governmental support to delineate what should happen in care models with the general population. So let's think about, for example, some of the laws that exist for return to play and children that are participating in athletics following injuries. All 50 states plus the District of Columbia have laws regarding a gradated return to play procedure following a mild traumatic brain injury. There's stepping stones that must occur, certain medical providers and sign-off that needs to happen before a child can return to play. If you review the legislation amongst those states, only 9 of the states write about anything regarding return to academic activity. The legislation is very particular to supporting that athletic sport environment, and maybe not so generalized that it provides professionals, educators, family members with information about what to do with the rest of the child's experience, the rest of the environments that the child is going to participate in. So that brings us to think about what special education services might be out there for this population. Special education services are not being utilized very much for children with traumatic brain injury, and in particular for individuals with mild traumatic brain injury. A very small number of students actually receive special education services due to a diagnosis of a traumatic brain injury. Much less than 1% of the population of children that get special education services are receiving them because of a TBI. When that's all TBIs of all severities. So if you think about how many children are receiving services for a mild traumatic brain injury, it's going to be much, much less than that. So again, we have some supports in place for children dependent on maybe their mechanism of injury, when and where they receive this injury, what institutions or organizations they're already involved with. But for lots of other kids that might have a mild TBI, maybe falling off their bed, for example, we have less support and less infrastructure in place to make sure that these children are going to be successful. Okay, so I'm just going to briefly walk through kind of a potential timeline of services that we might consider for a child who has a traumatic brain injury. Kind of towards the bottom here, we see indicators of what might happen in terms of a return to play. So if a child is injured during organized sports and the legislative efforts kick in and we have graduated return to play protocols that are put in place by the organization, we can see that typically what's going to happen is a gradual return to activity. It might start with some sort of rest period following an evaluation. The child may be allowed to start to do some activities, and as long as they're asymptomatic, they can build more into that, maybe more complex or for longer periods of time. And finally, the hope is that within just a few weeks, as we mentioned, then symptoms will be resolved in that population. There are some efforts to potentially test athlete populations before they fully return to play. So in this scenario, you may have baseline assessment on the child, and then when you are clearing them to return to full activity, you might repeat that baseline assessment. As you can see, a lot of infrastructure really built in to support that population. There are less things available for support of children in the general population. So a lot of times what happens is that if a child experiences an injury, they may seek medical care and they may be told by a medical professional to monitor things. Here's some symptoms you might expect. Here's some stuff that might happen over the next couple of weeks. But there isn't going to be a very systematic procedure for support. Within a couple of days, it's possible that there may be some referrals to services. So typically these referrals don't happen immediately after injury, but if we see some prolonged symptoms or symptoms are being monitored and we see they're not getting better or maybe potentially getting worse, then hopefully some referrals might happen. The issue that we see, as I mentioned before, is that there could be prolonged recovery for this population. Typically, athlete populations, we're thinking a couple of weeks for full return to play, and for children in the general public, that may or may not be the same. So that brings us to talk about the guidelines that have been created by the Center for Disease Control relative to the management of children with pediatric mild TBI. So these were developed in 2018. You can see by a very long list of professionals who work in a variety of domains of rehabilitation for brain injury and specifically pediatric brain injury. What this is a series of guidelines, recommendations, and sub-recommendations that fall across several categories: diagnosis, prognosis, and management following injury, specifically for the pediatric population. And what these guidelines and sub-guidelines have done is collected all the evidence and the research and the literature that's out there, plus expert opinion, and provided professionals with ideas or recommendations, I won't say mandates because they're not really, that give you a level of obligation. You must do something, you should do something, or you may or might do something. What I like about these recommendations is they provide a nice foundation universally for what a professional might need to consider regarding the management and care of this population. There are some drawbacks to these guidelines, however. A couple are related to the nature of the document itself. The document is not going to tell you what professionals should be involved, on what day you should do a particular thing. It's going to talk about assessing, but it's not going to tell you what assessments to use. So these are quite broad in nature. So they really are a 10,000-foot view of all the considerations in the areas that you need to think about in caring for this population, but they are not going to provide you with a step-by-step procedure for how to care for people from day one to the time that you're discharged and they're fully recovered. Another thing that is difficult about these guidelines are that they don't delineate what you might do for a very young child versus a 17-year-old adolescent. So we will talk about how your practices might differ quite vastly depending on the age group of child that you are going to be caring for. And there isn't a lot of advice or suggestion here about how to differentiate those practices. Furthermore, it's possible that you might be thinking about this through the lens of a medical, acute care, emergency medicine viewpoint, and somebody else is thinking about this from a special education academic setting viewpoint. There are not differences in the guidelines relative to setting either. So again, great foundation, a really great place to start, but some of the specifics are missing. So what we're going to do now is talk about some of these different categories that they provide guidelines and recommendations for. And I'm going to attempt to fill in some of those specifics for you, hopefully give you ideas of particular assessments, for example, that you can use, or strategies that you can teach these children to manage their symptoms, etc. So let's start with diagnosis. The CDC talks about diagnosis as a relatively broad category. I mentioned to you earlier that an objective diagnosis of mild TBI is truly based on observable signs and reported symptoms. Diagnosis in terms of the CDC category is going to bring in a lot of other factors that allow you to basically evaluate the child across a variety of areas and domains. So this might include imaging. It might include cognitive testing or standardized assessments. There could be some biomarkers that are discussed. So we're going to dive into this idea of diagnosis just a little bit further. One of the things that the CDC says is that health professionals should not routinely gather brain imaging data. I mentioned to you before that when imaging happens, you may or may not see any structural changes that appear. So CT and MRI are going to be useful, according to the CDC, to rule out anything severe. So if there is potentially a concern that there is a brain bleed of some sort, for example, then imaging might be helpful to reveal some of that. But in mild injuries, that's not typically going to be present. Only about 7% of children have an intracranial injury that's actually identifiable versus imaging. So the CDC is recommending that routinely this is not something that should be in the practice. One of the reasons is that these conventional imaging methodologies are just not sensitive enough at this time to detect changes. There are some other options that are emerging, but right now the CDC doesn't have enough evidence to say whether they should be routinely used right now. So the recommendations do talk about single photon emission CT, skull radiographs, and at this point say these methods should not be used. The exception should be that imaging is ordered and obtained for this population. Conversely, the CDC provides us with something that health professionals should do. So they state that health professionals should use an age-appropriate validated symptom scale. I'm going to immediately throw a few wrenches in that idea. The psychometric evidence for use of symptom scales in children is, I'm going to politely say, very weak at this point in time. Think about why. Can a 1 or 2 or 3-year-old tell you with great reliability and validity the symptoms that they feel they are experiencing? Probably not. I have a 16-month-old, and I can tell you if I tried to ask him about how he was feeling and what was going on, I wouldn't gain very much data at all, and it would probably be unreliable. So symptom scales are going to be a problem when we're thinking about maybe the younger end of this pediatric scale. Alternatively, something that might be really helpful are structured interviews. What this means is that it's potential to talk to the caregivers, those that are around the child routinely, and discuss the changes that might be seen. Here's some areas you might talk about. So eating, sleep patterns, mood, behavior. Are there any regressions in milestones? So in my practice, when we have a young child that comes in, one of the things that I have the parents do is fill out a developmental inventory about their child. And I ask them to fill it out first with their thoughts relative to what their child was doing prior to the injury. and I give them one color pen to go through and fill out the developmental inventory. Then afterwards, I walk through that developmental inventory with them, and I ask them using a different color pen to mark what they think is different following the injury. So they really have to think about both sides. One of the things that's hard about children is that in any given day, hour, minute, they might appear a little bit differently, right? There's lots of things that can influence the behavior of a young child. So you want parents to really think about what has been a change globally from pre to post injury. And that interview can be really helpful, as well as combining some of those developmental milestone inventories. The CDC talks about how use of some standardized assessments should really not occur exclusively. So they're not telling us that we can't use some standardized assessment methods, but that it shouldn't be the only method that a professional relies upon. So if you are used to administering something in particular, example, the standardized assessment of concussion, or the SAC as it's known, as your only measure, the CDC does not recommend that for a variety of the reasons that we just talked about. So relying on only one source of objective and potentially subjective data is not going to be recommended in an assessment or a diagnosis procedure. Instead, what you might do, as I mentioned, is think about some of those standardized assessments that you may traditionally use and supplement them with some other things. So here's an example here of something that is exclusively meant to be for younger students, age 5 to 7, and it's a post-concussion symptom inventory. So it's a self-report form that has been adapted for younger pediatric populations. So the wording is particularly comprehensible by kids of this age. The questions are asked in a particular way that hopefully information regarding experienced symptomology can occur relatively accurately. And the nice part about some of these scales is that they talk about not at all, the symptom's not happening to me, I think it's happening a little bit, yeah, I've had that before, or oh man, this is a problem, it's happening a lot. So even the terms that are used to categorize the symptoms are really digestible by young children. So again, some supplements that you might consider to enhance the traditional assessment measures provided. Another component of diagnosis that we talked about earlier is potentially the use of something objective like a biomarker. There is not a lot of evidence currently to suggest that these are reliable and valid measures yet for diagnosis of mild traumatic brain injury. However, there's a lot of evidence emerging to support the use of these in the future. So as of right now, and 2 years ago in 2018, the CDC does not recommend using biomarkers outside of the mechanism of research. So as I mentioned, there's a lot of research emerging to support this idea, but in clinical practice, we're not quite there yet. That translation to clinical practice hasn't actually occurred. So really at this point, they're saying there's insufficient evidence to recommend any of the biomarkers that currently have been studied, particularly in pediatric populations. There's a couple that are listed here. Some of them have proven to be quite sensitive, but not very specific. Others have been shown to differentiate between individuals with and without an otherwise diagnosed mild TBI, but again, we're just not quite there yet. So this diagnosis piece is a little bit tricky due to some of the lack of evidence really getting us to that objectivity at this point in time. So let's think about this in terms of prognosis. Maybe we know that an injury has occurred, or we suspect for a variety of reasons that an injury has occurred, and now we want to guess, predict, consider what might happen next. Do we expect to have a traditional trajectory of recovery? Do we see anything that is going to be alarming or concerning? And potentially, how does that influence what we do next in terms of services, related health professionals, and things like that? So under prognosis, again, a really pretty broad term, the CDC considers a variety of different categories. They're thinking about counseling and education, about what recovery might be, They're talking about very good history about medical and social factors that might contribute, talking about tools to track recovery, and considering again what interventions might be appropriate if we suspect a poor prognosis. So here's one of the things that the CDC says. Healthcare professionals should counsel families and the patient or the child themselves about prognosis. This is an interesting thing to consider because there's some research out there that talks about how this education and counseling occurs actually is going to influence the recovery that people experience. So you want to be careful as a medical professional not to alarm people, but you also don't want to undervalue the symptoms that people say they are experiencing. So it's a little bit of a balancing act here. You should counsel them that 70 to 80% of people with mild traumatic brain injury, particularly children, will not show difficulties past 1 to 3 months. But in your head, you should be thinking on the flip side, there's that 20 to 30% that will, okay? So it's a balance about how we talk about this information. You also may need to talk about some of those risk factors that we mentioned that may increase or decrease the risk of having prolonged recovery, knowing that those are only our best educated guesses. That data is based on potentially large or small samples that may or may not match the characteristics of the child that is sitting in front of you. So we need to remember that although we can provide generalized expectations regarding prognosis and recovery, we have to be clear that people may or may not fall into those trajectories. What we know about the value of education is that educating a patient early on will result in less symptoms at 3 months. So the importance of educating a patient cannot be understated here. It is going to be a very large component of what you're doing with your time, but also with helping the person kind of manage and figure out what's going to happen with them long term. Here's some examples here about some things that you might use or consider if you're trying to educate the child themselves. That can be a little hard, right? Let's say we're talking about a 6-year-old who was playing with their friends on the playground, now has a suspected injury, and we're trying to tell them what's going to happen to them. There are some really great resources out there that are child-friendly that can help you. So one that I really like is this link here provided to you, Frontiers in Brain Science, for example. And if you go to these sites, you can type in brain injury and you get a ton of different kid-friendly resources. And these resources are written by experts and professionals, but they're also reviewed or evaluated by children. So children are involved in the process of creating these to make sure that they're really family-friendly and child-friendly. So you can find topics such as caring for your brain, returning to school after a concussion. The effects of concussion can be long-lasting. So there are many, many resources when you go to this site that you might rely on to help start the conversation when you're educating and counseling the patient, the child that you're working with. So in my opinion, this education is probably one of the most important, if not the most important things that you can do, particularly with the adolescent population. One of the things that you're going to see with older kids is that they're really going to struggle to potentially hide their symptoms. They want to go back to school. They want to go back to sports. They want to be engaging with their friends socially, but they may still be having a hard time doing so. So the education piece can be really valuable to let them know that this is normal, that lots of people experience symptoms after these injuries, that we can expect and hope that they are going to get better, that there are ways they can manage their symptoms. So for adolescents who were thinking about autonomy, self-awareness, and self-care, we really want to make sure that we're educating them. And as I mentioned before, this early education can be really valuable for both the patient and their family members long term. Another thing about the adolescent population that I want to point out is how important it is for them to be involved from the beginning in their care. So it starts with this education component. By talking an adolescent, a teenager through what we expect to happen, what the symptoms are that they're experiencing, how these symptoms might impact their life, we can start to give them ownership over what's going to happen next. Think about a school. If you're telling a student that they need to notify a teacher when they need extra time on an assignment, they have to know that that is a thing that could happen because of their injury. They have to know that there are accommodations they can ask for and request. So it starts really early on, and it's going to engage people again in that ownership portion. So what are some things you might educate about? So to say that you're going to educate and counsel people is great, but what does that really look like? Some areas that are suggested across the literature include basic facts about concussion. Things about how many people we expect to recover. What are some of the typical symptoms that you might experience? You might have problems concentrating. You might feel a little foggy. You might study for tests and have a hard time remembering what you studied. You might read a whole page in your textbook and get down to the bottom and not recall at all what you were reading, and you're going to have to start over. So really talking to them about that normal expectation, normalizing some of those. You're also going to want to educate them about the fact that they're going to have to advocate. So they're going to have to tell parents and teachers and coaches about what's happening with them. They can't expect that everybody's going to know those symptoms that are happening inside, right? We talked about that idea of headache being something that isn't observable. So unless we teach a child to tell us when they're experiencing a symptom, then they're not going to know, and they're not going to be able to attribute that back to their injury potentially. I had a college-age student who experienced multiple injuries during high school, and she got 3 mild traumatic brain injuries in the course of 18 months playing soccer in her senior year. So she was about 17, 18 years old. A couple months after her 3rd injury, she was diagnosed with depression. And I was interviewing her about 2 years after that whole experience when she was a college student. And it dawned on her during that conversation that it's possible the symptoms she was experiencing in her mental health may have been related to the injuries that she experienced in that 18 months. And she didn't have any idea, because at the time, people didn't educate her. They didn't make her aware. They didn't counsel her on what to expect or what might happen. And so she had never made that link before. And had she been able to, she might have understood how to advocate for herself and ask for services and support earlier than she did. The last thing that you might really consider is educating on the deficits or symptoms that people can experience. So I don't know about a lot of you, but when I tell people that I work primarily in cognition, some of them kind of understand what I mean, and a lot of people don't. So I actually spend quite a bit of time talking to the kids that I work with that come through our clinic, telling them what attention is, talking about the different kinds of attention and how having problems or challenges with attention might influence their life. I also am going to talk to them about the working memory or communication, word finding problems. So they don't know what these things are. So we want to put labels on them, on those different skills or areas for kids so that they understand what it is we're talking about and what to look for. Okay, so specific deficits, talking to them about advocating for themselves, and basic concepts and facts regarding mild TBI and concussion. A couple of resources are really beneficial for you if you're working with maybe the older kid population. One of them is a program called AHEAD. This is created by the Colorado Brain Injury Alliance, and this is step-by-step 6 weekly modules that you can walk someone through or someone can walk themselves through where they learn about brain injury. So the program is very helpful because it tells you exactly what you need. There's scripts, there's worksheets, there's the list of materials that are going to be helpful. This can happen in a group format, an individual format, etc. So it's a really valuable go-to resource if you're thinking that you don't have time to reinvent the wheel, that you're not really sure where to start, but you know you want to value this component of education. This resource from the Colorado Brain Injury Association is very helpful. Another thing that I want to point out to you is a video series that I helped work on when I was living in Minnesota, and I was on the Minnesota Department of Health board relative to brain injury and spinal cord. So what we did was create a variety of short videos that talk about different concepts relative to brain injury. They include example stories, vignettes from survivors, as well as information about what those different things are. So there's one about mental health. There's one on executive functioning. Now, these are not geared towards the pediatric population, but again, may be okay for adolescents or young adults that you might be working with. So let's just quickly talk about some of the differences between these populations when we're thinking about education and prognosis. So when we're thinking about early childhood, and you're trying to figure out what symptoms people are experiencing, maybe you're giving cognitive testing, maybe you're trying to see where they fall on a continuum of development, etc. One of the things that we want to make sure of is selecting assessments that are going to make sense. What this might mean is you might be participating in a dynamic sort of assessment approach. So I'm a speech language pathologist by nature, and what I mean by a dynamic assessment is one where you might ask a child to do something, and if you see them struggling, you might intervene and try out a strategy or provide them with a support to see if they do better or they change kind of their performance on that task. You may also consider selecting assessments that are meant for children with acquired brain injury broadly. So there are some standardized assessments that you could select that are not created specifically for the mild TBI population, so normative data may not be available to you. However, you can use that information as more descriptive in nature. Or again, observational in nature to see how children are performing the tasks or where they fall across a spectrum if there are norms. The idea of using some standardized testing methods is you're going to get information. So although we don't have a lot that are made specifically for the pediatric population, and although there are not a lot of norms for mild TBI, we don't want to throw these out completely from our assessment battery. So combining them with interview and symptom scales could be really valuable. Here's a list here for some examples of different standardized assessments or scales that you might use if you're working with the young child population. As I mentioned earlier, one of the things that I often do is ask parents to fill out some developmental inventories. So here's some examples of some of those scales or inventories that you may wish to consider, along with some ideas of research and evidence to support these and provide some norms for you. What if you work in a medical setting specifically? Well, it's going to look a little different. People in a medical setting might get a one-time snapshot to support the child, to evaluate them, to determine prognosis. You may not be involved in the long-term management and care of a child. Let's say you work in an emergency room. You may never see that patient or their family members again. The things that you try to accomplish in a session or in a meeting with somebody may differ dependent on who you are, where you work, what your goals are. One of the things that's really important if you're working in a medical setting is helping set up the paper trail. One of the things that we see in the academic settings is that many children don't have any documentation regarding a potential or somewhat objectively defined mild traumatic brain injury. Let's say a child starts experiencing problems in first or second grade with learning and reading, and they were in a bad car accident at the age of 3. The child may or may not be able to receive services because of that car accident without that paper trail. So individuals in medical settings can be really, really valuable in helping start that process, getting things down on paper and documented, educating parents about what they might be able to expect long term to make sure that you're starting off the child really on the right foot. In a school, it might be a little bit different, right? Because you may have a child that comes in already with a diagnosis. You might have a child who experienced an injury years prior to when they start school. You might have a child who you already see on your caseload for something, and then they walk in on Monday and they say, I hit my head over the weekend. That happened to me when I worked in the schools quite a bit. I had this one high schooler who came in and said, a car just hit me as I was walking into school and drove away. And it was like, okay, we're gonna get working on that, right? So, it may look a lot different in a school setting than it does in an academic setting, but the advantage is you may have pre-established relationships with these children. So the longevity, the continuum of care, the building of a supportive network is probably going to be a lot easier in academic settings than it potentially is in medical settings. So when we think about prognosis, one of the important components that the CDC talks about is not only looking at the factors on day 1 or day 2 when you see the child first for care, but thinking about long-term monitoring. We're going to need to gain information farther than just at the time of injury to really know what's going on and make our best guess and determine what's going to happen in the next stage, which is management. Long-term monitoring is really important. One of the things that's hard with this population and with any population is that we may not have a very good baseline to go off of. We may not have data about somebody prior to one of these injuries occurring. So monitoring over time is going to be very important and valuable, particularly in those cases, as we don't have a pre-post sort of data element to go off of. So let's think about high schoolers in terms of this particular category. When we are thinking of testing for this population, there's almost no data to support what you might choose relative to mild TBI. So again, some sort of combination of self-report, standardized assessments is going to be really valuable. Balance testing in particular is going to be important for this population and for athletes. So consider that as one of the tools that are going to be in your kit or referral for that if necessary. I have here a list for you of some assessments that may be helpful. Several of these are self-assessment tools. They may or may not have mild traumatic brain injury norms. There may be more severe norms. However, many of them go down to 12 years old. So they are a test that may be traditionally thought of for adult populations, but can be used as young as 12. So for adolescents, you can steal a little bit from some of the adult literature. Another thing that I want to point out that is a really great test is something called the FAVORS. There is a student version, and the idea of this test is that it's meant to be a functional assessment of status created for individuals with acquired neurological disorders. And there is a version that's specifically made for student young populations. Again, mild TBI norms, not necessarily, but you can use the information to help guide you and figure out what the plans are next. All right, so let's wrap it up kind of thinking about management. We started with, has an injury happened? How do I determine that? Then we talk about, what do I think is going to happen to this child? How are they doing right now? What prognosis might there be? What are next steps? Now you decide next steps are needed. Okay, so the CDC talks about how you're going to go through managing, treating, caring for this population kind of long term. This particularly includes that return to school or academic setting component. So I mentioned earlier that we don't have a lot of legislation relative to return to learn, but these CDC guidelines can be maybe valuable if you're feeling like you're missing some of those ideas or strategies. So when you think about how to treat somebody, a variety of factors is going to go into that. How many sessions are you seeing them for? Do you expect to be with them really long term, or is this going to be a short relationship? Where do we have to think about where they're going to be? What kinds of settings and situations? What are their premorbid factors? So as a rehabilitation professional, as a family member, you have a lot of different components to consider in determining the best type and levels of care for this child. The CDC has, I mentioned, these guidelines and these sub-guidelines, and they talk about these different areas of consideration: patient education and reassurance, cognitive and physical rest, psychosocial and emotional support, return to school management, post-traumatic headache, vestibular and ocular motor dysfunction, sleep, and cognitive impairment. As a speech-language pathologist, I feel pretty confidently that I can at least contribute to some of these. There are other areas where I feel less confident in my skills. I ask parents about sleep, but that isn't in my area of expertise. I ask patients and parents about headaches and vestibular and ocular dysfunction, but it isn't necessarily in my professional domain or wheelhouse. So I point this out to talk about the idea that there is likely not one individual who can work to manage all of these different areas recommended by the CDC. So a multidisciplinary team is going to become really, really important. So what that looks like for young children is probably what we consider as a family-centered approach to care. It's going to be quite difficult to treat a particular deficit or symptom in a young child, potentially. So we want to look at this more holistically. What we want to do is really think about intervention that goes with collaboration, individualized to that child, and really this idea of family-centered care is just best practice in intervention broadly. For elementary or school-age children, we might start to think about things that are a bit more formalized. So are there academic accommodations that can be made? Do we need to provide services such as an individualized education plan or temporary special education services like a 504 plan? Do we need to work with classroom teachers that are going to be with this child on a daily basis to educate them about expectations, concerns, etc.? For middle and high schoolers, it gets a little bit easier. We can start to take some of the evidence that we have from the adult populations and figure out how to adapt those for teenagers. Okay, so what I mean by that is in kind of both the acute and chronic stages of recovery, we might be able to say, you know what, they're having symptom A, and I know some really good evidence-based methods to directly treat or restore that kind of symptom in adult populations. We can do that with adolescents. These could be things in my field related to things, as I mentioned before, attention, working memory, processing speed, word finding. So the idea here is that interventions associated with neuroplasticity, with retraining the brain to function as it did pre-injury, those can be really helpful and potentially have a place here in the care of adolescent or older children populations. One of the things that's really important here, though, is incorporating home programs. So it's not going to be enough that you ask the child to practice something over and over again, that they get better at it when they're with you for, 30 minutes once a week or every 2 weeks or something. These home programs and this consistent drill and practice is going to really help them succeed. Another thing that is highly valuable with this older child population is going to be training them to use strategies. There's not going to be someone sitting with the teenager all the time in the classroom. There's not going to be someone telling them what to do all the time or, kind of that little voice of reason on their shoulder isn't going to be present. So we want to train older kids to initiate strategies on their own. This could look really global, like let's say they're having a problem staying organized. If they're having a problem being organized with anything, maybe we teach them how to use a planner. Okay, so they can keep their life organized in a variety of ways. They can make note lists, they can, checklists, they can organize dates and times and all of that kind of thing. It could also look that maybe they just need help organizing their social studies homework. Okay, so you may think really broadly about these strategies you can teach to help them across a variety of areas of life, but it also might be very, very specific. So it's going to be important here that we listen to the child about where they're having concerns and problems. I can think, for example, that I had a student come to me once and he was talking about how early in the day he did great. Then, he was really, really struggling in math. He couldn't concentrate. He didn't ever know what the teacher was saying. He needed things repeated all the time. We were like, okay, let's get to the bottom of this. So we started asking questions. Well, when is math class? It's after lunch. Okay, so you just ate a big meal. Are you feeling sluggish? Have you had really hard classes in the morning? We can kind of figure out what the problems are and then give the child strategies to circumvent that. So in that kid's case, we saw if we could change his schedule during the day to accommodate for something so that the harder classes, the things that were more cognitively taxing, could occur in the morning and then not so much in the afternoon. Or could you teach them to embed breaks into his life so he can work on class stuff for 30 minutes and then he's allowed a 10-minute break to help give his brain a rest and get him focused and back on track. So these are the things that you can work on with the child and ask them for their suggestions to figure out when they're a little bit older. Other things that might happen could be just the basic stuff that you and I do every day. So if you're in the olden days ever had to remember a phone number from the time you looked at it in a phone book, for example, and by the time you walked over to your corded phone, you probably every step of the way were rehearsing that number in your head as you went over there. So that's a strategy that you might not realize you use, but could be highly valuable to a child who, for the time being, is having problems remembering things in a short time frame. You can think about all of the stuff that is maybe potentially common sense, work with the parents, work with the child to figure out some strategies they can use on their own. Another one that I really like is when you're working on memory, having the student come up with some sort of imagery that's maybe funny and associated to the fact that they have to remember. So they can conjure up a fun or interesting image that makes them think about that particular piece of information. So there's lots of things that you can do that probably all of us do that can be relatively normalized, and if they're internal, doesn't make the child look any different. Other things may need to happen that we might call an external strategy for management of symptoms that may or may not be typical in that setting. Maybe environmentally things need to change. Maybe for a while the child needs some specialized seating to reduce distractions. Maybe they need, as I mentioned, changes to their schedule. Maybe they need a peer to take notes for them in the classroom, and so they can concentrate on listening and not concentrate on listening and taking notes at the same time. Assistive technology can also be really helpful. There are many things you can do that won't make the child, or particularly an adolescent, feel different. I can think back to a time where an accommodation for a student that was really helpful while they were recovering was having tests read to them. But instead of having someone from the special education team sitting there next to the child reading them the test, we actually pre-recorded it. The student wore headphones and took their phone out and just used a little QR code to have each question read to them via their headphones. Okay, so it was a way to make everything look a little bit more typical and usual, but still provide something for that child to have accommodation and support. Okay, so you can get really creative with these things. The idea being you probably need to think about these strategies, these direct interventions, these other things that you can do to manage symptoms in the interim while we hope that these children recover, or long term if we have a protracted, prolonged recovery and we're seeing symptoms over time. So academic accommodations in general are going to be a really big global piece for this young student population. We would make probably accommodations in vocational and workplace settings for adults, so we want to make sure we do the same for children. What I see happen, however, is that many people put an accommodation in place and never revisit it. So it might stick with a child for years that they get extended time for tests, when really it's no longer warranted after maybe a few months. The opposite can happen. You can see that people say, well, right now he doesn't need an accommodation, so we never revisit the idea of whether some sort of accommodation could work for the child. So they go months and months and they start to get worse, and people think the brain injury has passed, and we don't consider supporting the student later on. The idea of early and often is a really big tagline for me here when we think about how to manage the symptoms that these kids are having, because it's got to be really malleable. It's going to change over time. The thing you do on day 1 is not the same thing that might work on day 30 or 60 or 90 or beyond. So we want to provide children with the amount of support they need, but not too much and not too little. There is such a thing as over-accommodating a child. So we want their feedback about what their needs are. Again, that advocacy comes in. If you educated them well, you did assessments that reflect their current status and ability, then you can really figure out the accommodations, the needs of that child that are going to bring them up to performance and independence of where they want to be. What does this all mean? Well, like I said, the CDC guidelines are really helpful. They're a great document to have handy to read through, to give to your entire rehabilitation team or your academic team, and talk through how they might work for you. Every setting is going to have different policies and procedures. One emergency room is going to look completely different than another in how they manage children that walk in with suspected mild TBI. These are a great place to start, but they aren't something you could just pick up and use tomorrow. So you want to consider all of these different areas as they relate to your practice, your setting, the team that you have, whether you're seeing little kids or older children, whether you typically see people on day 1 or day 120. So they're a very good start, very helpful, but globally really need to be adapted and the literature reviewed to figure out how they might work for you. You are welcome to reach out to me if you have any questions about this or if there are additional resources that I could provide you regarding this topic. Thank you all for listening today, and I hope to see you soon.
Hi, my name is Brittany Sweeney Lawson, Resource Facilitation Manager for the Brain Injury Alliance of Arizona. Thank you so much for watching our presentation today. We hope you found the information helpful and that you'll be able to use it moving forward. If you are seeking continuing education credits for this presentation, please return to the video's launch page and click on the post-viewing test. This will bring you to the content-specific questions to complete. Once you have achieved a passing score, you will receive the instructions for obtaining the certification paperwork through our CEU Management Group Empowerment Research. Again, thank you for your time, and remember, if you have any brain-related questions or resource needs, contact us at the Brain Injury Alliance of Arizona.